Kalamara, everyone. Great honor. It's a great honor for me to be here today. Thank you all very much for coming, and to be the first speaker of the first international conference on exercise medicine is such a truly honor. So thank you both very much for the invitation, and to everyone here for attending. Before I get going, I thought I'd share a little bit on my background. I'm trained as an exercise physiologist at the University of Miami, but really quickly my pathway took me into public health. And I very much view exercise as medicine as a public health initiative. And it's a beautiful initiative in the sense that it combines exercise science, sports medicine, public health, all in one combination. And I'm hoping to show that today in my talk. Now, my day job is typically as a university professor. As mentioned, I work at Durham University. But along the way, my night job has been working for the American College of Sports Medicine as a consultant with exercise medicine. So this is my 13th year doing this, and it's just one of the most glorious things I get to do is to work with people like those here at EIM Greece. So for me, it's been a very nice marriage and very synergetic between my work with exercise medicine and my research. And I've kind of combined it together at this place of promoting physical activity through clinic and community linkages, which I'll explain today. And I also want to get to the point of how the role of exercise medicine in Greece is really going to try and move forward physical activity promotion in the country. So I'll do that today by starting out and describing just what is exercise medicine, how we can integrate physical activity through healthcare settings. Then I'll give an example of that from the United States, exercise medicine Greenville. Talk a little bit about what other groups are doing around the world, and then maybe perhaps offer some suggestions for how people can get involved with exercise medicine here in Greece. So this is many of us who give exercise medicine talks start with this slide. And it's from our founder, the first president of exercise medicine, Bob Salas. And he said, what if there was one prescription that could prevent and treat dozens of diseases such as obesity, diabetes, and hypertension? Wouldn't you prescribe that to your patient? I mean, it's kind of a no-brainer. Of course we would, certainly. But that's not what's happening. So exercise medicine, this is part of what we're trying to get at, is when we look at what makes people healthy. And this is just a very broad generalization. We know that access to care matters. We know that people's genetics matters. The environment we're in matters. But we also, the health behaviors, what our choices, make a very big part of what makes us healthy. Yet when we look at what happens in a healthcare setting and how we spend our money, and this is very US-based, but I think it holds true in most countries around the world, we spend a very, very small percentage of our funds and our attention, our energy towards improving those health behaviors and more towards providing medical services. So why is this? I think healthcare systems, healthcare settings, they don't know how to promote physical activity. They're not set up to engage patients in a preventive medicine format with the infrastructure, the expertise to really move forward that lifestyle behavior change. So exercise medicine wanted to step in and try and fill that void. It started in 2007 as a presidential initiative of Bob Salas, his quote 2 slides ago. It was his signature initiative during his term as ACSM president. And most of the presidents, they come into ACSM, they have a signature initiative, it lasts for a year or two, and then you never hear about it again. Well, obviously, this is one of the most successful initiatives ever of American College of Sports Medicine. Here we are 17 years later, and exercise medicine is still on the tip of the tongue for ACSM. Along the way, we've had 2 great staff leads that I've had the honor of working with, Adrian Hutber and then Robin Stewart. And early on, we were really boosted by the involvement of the American Medical Association, one of the most important medical bodies in the world, saying, yes, we want to be part of this, we support exercise medicine getting going. Since then, this is just a very small sampling of other partners we have. We're just so fortunate that we really are partnering with people across the entire healthcare landscape in the United States, CDC, these different partners. It really is essential in making this a multidisciplinary initiative. So in 2014, we published what we call like our seminal paper. This is really where we lined up what is exercise as medicine. You know, spelled it out for people, kind of said, here it is, everybody, let's go. Since then, we have hundreds of publications on EIM. And this is just a sampling of a few I've been a part of. But I mean, if you type in exercise as medicine, the work of Bob Salas or Liz Joy or any of our leaders, you're going to find hundreds and hundreds of publications. But what happens is we still get people saying, what is EIM? Even our ACSM leaders will come to us and say, we don't get it. And that kind of puzzles me. I'm like, we have a website. Have you ever gone to our website? But I think some of the confusion about what exercise as medicine is it's such a catchy slogan, and everybody uses it around the world. And also, we created some of the problem, because when we started in 2007, the scientific literature, all the scientists, like Professor Philippou and everyone else, we're producing all this knowledge about how physical activity is so good for our health. But I'm not sure at 2007 if people in the public really knew it. Like most people did, but not everybody. So exercise as medicine really started out as this like awareness campaign. And we got all of our leaders and all of our partners across the world just screaming as loud as we could about the benefits of physical activity for physical, mental, and emotional health. And for about 5 years, that's what we really pushed. Physical activity is good for your health. It helps improve all these things. That's exercise as medicine. So that's what exercise as medicine became. And you know, every year at our annual meeting, we get like 50 abstracts for presentations on physical activity is good for your health. But we've moved away from that about in 2012, and that's what led to that 2014 paper. And we kind of operationalized what exercise as medicine is. Actually made it into a program that people could use and adopt to promote physical activity through healthcare settings. And that's one of the keys. It's through healthcare settings. So what we see exercise as medicine as is a community-based extension of that healthcare team for at-risk population groups. We can define at-risk however you want. It could be sedentary individuals, people not meeting guidelines. It could be people who are overweight or obese, have diabetes. Whatever you want to define it as an at-risk population group, that's what it's for. Giving them a cost-effective approach to become physically active and delivered in supportive, coordinated environments. That's what exercise as medicine is. So how are we trying to do that? Well, we view it as we want to establish physical activity as a standard of care in health settings. So what we mean by this is, you know, prior to this, people would go into a health setting and they'd work with a doctor. And let's get this doctor to change their habits and prescribe and talk to patients about physical activity. Then I got to work with this doctor and this doctor. And there's so many clinicians and healthcare providers that we're not going to get anywhere. So we want to start with the system itself. Get the system to adopt exercise as medicine, and then all the providers will have access to engaging patients in that program. So here's our vision. We want to make physical activity assessment and promotion as standard in clinical care, as I just described, and connect healthcare and the patients from healthcare settings with evidence-based physical activity resources for people everywhere and of all abilities. So that's our goal, that's our mission, and we've pushed that out across to all our countries around the world that are doing exercise as medicine. So in that 2014 paper, we kind of outlined this flow chart here with the inputs and outputs, and said these are all the things, if you really want to be successful with exercise as medicine, you'll see there's not a lot of exercise science up there. It's you know, you have policy and surveillance, education and training, evaluation, research, media. But right here at the middle is the topic of this talk, right? That clinic-community integration. And to me, this is what really is at the core of exercise as medicine, that clinic-to-community integration. So we kind of talk about doing this over 3 different steps, all right? The health systems, working with health systems, working with the communities, and then figuring out how to engage active health technology. So let's start with the health systems. When we go into a health system, we talk to a health system. And we in the US, you know, we have a very fragmented, non-nationalized system. We work with one health system in this state and another health system in this state. But I mean, still, any one health system is influencing millions of people, typically. We say, we'd like you to try and do 3 things. Implement this into your entire system, your clinic, your patient care process. We want to assess physical activity levels of your patients. We want to provide them with some sort of prescription or brief counseling. And then last, we want to make sure they get a referral to a physical activity network. So what does that really look like? Well, with the physical activity assessment, the first step, it all starts with assessment. And I always talk about this like blood pressure or body weight. I'm sure every one of you, when you go to your doctor in any country in the world, they're going to do your blood pressure and they're going to do your body weight. Always. Those are vital signs. So we're trying to make physical activity a vital sign. We get a lot of doctors and patients tell us, yeah, I talked to my patient about physical activity. Did you formally assess it? Did you use a standardized approach? Did you record it? And often the answer is no. We just had these informal conversations. So, well, would you have an informal conversation about blood pressure? No, you always measure their blood pressure following a protocol. Well, our protocol, what we came up with, is 2 simple questions. And I'm going to go through that in a second. But those questions help us determine whether an individual is meeting national or international guidelines, which is typically 150 minutes of moderate to vigorous aerobic activity a week. That's all we want to know. Are you meeting the guidelines or not? If you do anything more complicated, the clinicians won't do it. It's got to be simple, it's got to be quick, and it's got to match guidelines that they can signpost off of. So this is what the physical activity vital sign, or PAVS that we call, looks like in an EHR. 2 simple questions, right? How many days a week are you doing moderate to strenuous exercise or physical activity? You tend to see the word exercise in there because EMRs, they don't like extra words, so they use exercise sometimes. And then on average, how many minutes do you exercise at this level each week? So I'm a person that says, well, I get out and I'm physically active moderately 3 times a week for 30 minutes. Well, that's 90 minutes. We know they're just shy of international guidelines. We know they then maybe could use some more physical activity in their lifestyle. The benefit of using the PAVS is it's simple. It can be administered by anyone. I mean, clinicians tell us, I don't have time to do this. Okay, good. Have your medical assistant do it. Have it do it while they check in. Have it on a tablet in the waiting room. There's a million ways you can do this, and more now, when I go to the doctor, I'm filling out my questions online before I even go to the hospital. Put it there. It's quick. It takes 30 seconds. Sometimes people get a little confused. What do you mean by exercise? You have to define it, but it's really easy to do. And efficient. Like I said, anyone can do it. The physician does not need to do this. In fact, we don't recommend the physician do this at all. So the first example of this happening was Kaiser Permanente, where Bob Salas worked. He was a champion, got it implemented to their electronic medical record system in 2010. In the first year and a half, tremendous success. 86% of clinicians or patients had their physical activity levels assessed. So that just is like, what a great start. Way to go. Then they decided, well, as we're rolling this out to different hospitals, and Kaiser Permanente has many, many hospitals in Northern and Southern California, let's do a little natural experiment. The hospitals on this side of the room already have the physical activity vital sign, but the hospitals on this side of the room, they don't. What happens, what impact might that question have between this group and this group of hospitals and their patients? So they went through and looked at this, millions of patients, millions of cases, and they found that the hospitals that had the physical activity vital sign implemented into their EMR, they saw 12% of documented physical activity habits in the notes. Patients were 14% more likely than the patients at the other hospital systems that didn't have it to say, yep, my doctor talked to me about this. And there was a 14% increase in referrals. We also saw small but significant weight loss in patients. We also saw a reduction in HbA1c levels. Now think about this. The intervention was 30 seconds, 2 questions that took 30 seconds, and all of that happened just because we asked the question about whether they were active or not. Step number 2 is that physical activity prescription. So we know the patient now is at 90 minutes a week, needs a little bit of help. We also know some other things about their medical conditions, help us inform what type of prescription and what they should be doing. And there's a lot of different ways we can do this. Like, I mean, you can be creative in your community, and I'm going to show you some examples. But the first one I'm going to mention here is from New Zealand. Now, nowadays, when you hear the term green prescription, people are like, yeah, I know what that is. That has to do with parks and green and outdoor. Actually, the first green prescription came from New Zealand, started in the 1990s by the Ministry of Health. And it was really just a prescription program where the clinicians would write out a prescription and give it to the patients. And early on, they said, okay, well, this group of patients will give a written prescription, and this group of patients will just get oral advice. And what happened? And of course, we see that the written prescription had a 15% greater chance of improving their physical activity levels. So nowadays, the green prescription is often tied into parks and being outdoors, but the original green prescription, and this still exists in New Zealand, but I think now they don't give a written prescription. I think now it's more electronic. So if you ever want to read, this is still a prime initiative of their government. At ACSM, what we've developed is an exercise EIM prescription pad. And this is actually the front and back is what you're looking, just side by side. The idea is you can, a doctor will give it and circle and you know, write in any notes and sign and say, here you go. This is what I recommend for you being physically active. This was developed by the leaders of ACSM, our presidents, some of the best scientists in the world. This has been copied in other countries, Canada, Australia. And I had a really neat story last week as I was preparing for this. One of our ACSM leaders posted on her Facebook account. She said, I just moved to a new city, and I went in to see my doctor for the first time, and look what he gave me. And she has a picture, and he had actually printed this out. It's freely available on our website, printed it out, filled it in, didn't know she was one of the people that actually helped develop it, and he's giving her one of these. And it was like probably one of the greatest honors of her life is that our work is actually being used by people out in the real world. So if you can go in, download these, give them out to your patients. You know, it's one way to give a written prescription. Another thing we've done and developed, and it's, again, these are all freely available on our website, is we've developed these prescriptions for health. And so the one here on your left is just regular guidelines, and it's geared for patients. So our idea with this is that as a clinician, they would print it out and give it to their patient. But we also have this on diabetes, people recovering from stroke, frail older adults, women who are pregnant. And it's meant to give guidance customized for their health condition or life situation about how to be physically active. We have translated many of them into Spanish, so this one's about losing weight, how to exercise and lose weight. But we don't have any of these in Greek. So if anyone's looking for a project here, I'm sure EIM Greece would love to have some of these translated so they can use and help disseminate these throughout the country as well. Now, in the US, we also have this park prescription program. It's not part of ACSM, but it's something that a lot of organizations got to. Listen, it's a great resource. We have parks. We have people that do activities and programs in park, and let's get people out and walking. And I'm like, hey, any options we can give our patients to become more physically active is a good option. A decade ago in Boston, I just love this example. I don't think this exists anymore, but they got together and they said, we have a bunch of, you know, underserved populations here that can't afford gyms, that can't afford these things. Well, why don't we give them like $5 a year membership to these bikes? And then so not only can they get from one place to the next easier, but they can be physically active while doing it. So they would give patients prescriptions to these bikes. And I thought, what a brilliant way to do. So there's just a million different ways that we can develop these prescriptions. So the last of the 3 steps that I mentioned was giving a referral to those community resources. And I think this is one of the most important parts. You know, because in the healthcare setting, doctors, nurses, the team, you know, they're going to spend 10, 12 minutes with you on average. So 30 seconds for the vital sign, printing out a prescription takes another minute or 2 on the way out. But making sure they leave with this referral, I think, is really the key part of the whole thing. So when you talk about referrals, probably the most well-known referral scheme is what we have in the UK, the exercise referral scheme. And I'm still learning this and you know, trying to understand, because it's promoted by the government. It's a government initiative, but it's enacted locally. So every community kind of has their own exercise referral scheme. But with the government's backing, it really blossomed, especially in the early 2000s, 800 schemes around the country where clinicians in healthcare settings are referring people to the local, they call them leisure centers, the local gyms, the local physical activity programs. And there's been so much evidence and publications on this. I mean, you just type in UK exercise referral scheme, you're going to see it in Scotland, the Wales, all over England. And it's another way of getting people that referral and connecting them to those community physical activity resources. When we started this with exercise medicine, we really had this vision. We said, okay, we're going to develop this online repository. And a clinician could go in and say, okay, I'm in this area of the country, here's my zip code, and here's all the resources, here you go, patient. The problem with doing this, it's very hard to keep them up to date because people are always changing, programs come and go, people move. So we haven't really mastered this at all in the US. It's kind of a work in progress. We're working on something right now, an exercise professional registry, and I think that has great potential in 2025. But I will say the one place this has worked really, really well is in Singapore. Our exercise medicine Singapore team, they do training of exercise professionals. They are the training program for exercise professionals. And once you pass their training program, you go on their website and you put all the different areas. And they want to put their names, they want to keep it updated, because then they work with all the doctors who've gone through training programs, and the doctors are taught, here's how you go in and find the people you can refer to. And so they have a really nice system in Singapore that I think works really well, and much better than what we have yet in the United States. So there you go, our 3 steps, right? Patient comes in, we're gonna assess their physical activity levels. It's a vital sign, it's important, it starts the conversation, we have to do it. Number 2, we're gonna get them a prescription, maybe even have a brief counseling session, give them some advice, encouragement, get them going. And then 3, they're gonna leave with a referral to a physical activity resource out in the community, okay? That's all we talk to a healthcare system about doing. Now in reality, this takes years and years to get into a health system. But once you get it in, it's really hard to de-implement it, but it takes a long time and a lot of work to get it started. So number 2 is the community side of things. It's no good developing this whole clinical side if that referral, there's nowhere to go to. And one of the most important things when we work with doctors, and we just had a roundtable in the UK about this 2 weeks ago, is that the doctors and health systems are terrified to refer people to a community resource and something go wrong, and then they're gonna get sued, and they're gonna be held liable. So with exercise as medicine, we realize how important it is to develop a really highly trusted, skilled, professional physical activity network. And we refer to this as the 3 Ps: programs, professionals, and places. We've also kind of added in over time self-directed resources. We realize some patients, they're going to take that prescription, throw it away, or leave it in your office. But if you can maybe hook them up to an app or online programs, they might be more likely to do that. So here's our network, right? Those professionals, programs, resources, places, it's all there. I firmly believe in my work, my research, we have enough in our communities to get people active. We just don't have the connection. You know, I tell a story about, I was doing work in Colombia, the country of Colombia, in Latin America. And the Ministry of Sports had developed these amazing physical activity programs. They had 300 professionals across the whole country, and their entire job was just to put on free public physical activity programs for groups. I mean, they're engaging tens of thousands of people. I go, have you ever talked to the Ministry of Health? No? Why? Well, because there's everywhere you offer these programs, there's hospitals and health systems and clinics and patients that need to be in your programs. But there was no communication. And I go, if you can't trust the Ministry of Sport to offer a good program, who can you trust? So even at that level, just very simply, there was no communication. So it's really important that we develop these community sites. I'm not really a healthcare person. Well, that's okay. You're a community person. We need your help in building the network. So I do want to mention something about the credentialed exercise professionals, right? In the US, we have 1 million different certifications, and doctors like, we don't know who to trust. We don't know if this certification is any good or that one. You kind of recognize ACSM, maybe you've heard of this one. So we said, okay, well, we're gonna develop something called the EIM credential. And it's like a continuing education that layers on top of this certification. And it's actually about 12 to 16 hours just teaching current exercise professionals how to deal with patients coming from medical systems. So how do you deal with someone who has diabetes? How do you deal with a pregnant woman who wants to become more active, right? So we've realized the need to do this, and the health systems are starting to say, okay, if that person has an EIM credential, we know that they have an undergraduate degree, we know that they have certification, and we know that they went through this extra training. If they have that, we'll trust them. And so we've started to see, okay, the referrals are flowing a little bit more easily to that. And I have to say that what I think this is one of the strengths of our EIM Greece team is they are really, really good on the side of the exercise professionals, really working hard to make sure those standards and what they're doing on the community side and developing this network. And I think this is really, really key because many doctors and many health systems will not refer unless they really trust the person on the other side. All right, so there we go. We have the hospitals doing assessment, prescription, referral. We have the communities with that network of programs, places, and professionals. But again, like I said, in Colombia, they don't always talk. They exist. We have, here in Greece, I'm sure in Athens, you have a health hospital and across the street is a gym and they're not talking to each other. Even sometimes within a hospital, you'll have wellness programs. And you say, well, doctor, are you referring people to that program? So, no, I don't know anything about it. In the same hospital. So I talk about this, and this is really the intersection of my work, is building this bridge of trust. How do we get these two entities, very different entities, a healthcare system, health services delivery, talking to those exercise professionals, the public health professionals in the community that are doing these programs. And that's called, that to me is the bridge of trust. And that is the big question. So we have a lot of things to do, getting this into healthcare, developing those community resources, and then figuring out how to get them to connect. So the last part I'll quickly mention is just about active health technology. And this is something we've had. And I've had this slide for 10 years. And it's just amazing to see what people are doing with technology over these past 10 years. But if you kind of look at this, this flow that I've talked about, where does technology fit into it? In the first three, assessment, prescription, referral, that's that healthcare module. We definitely need that, right? We don't want the physical activity vital sign done by hand. We want it into the electronic medical records. That's technology, right? Then engagement and enrollment, that's that bridge of trust. So how can we transfer patient information using technology to people that will engage and enroll people in the community programs? When they get to the community programs, how can we officially track their participation, monitor their physical activity levels, look at the outcomes, and keep it in a central place that, say, the Ministry of Health wants to know or the insurance companies want to see what's going on? We have all that information stored. And then last, how do we complete that feedback loop and say, okay, this is what's happening with the patient. They've come to our 12-week program because of your referral, and here's what happened. So there's a lot going on there. And we get a lot of technology companies coming to us and saying, well, we want to try and integrate the Fitbit so it goes right into the EMR. That's one thing everyone's trying to do. We're trying to do these different things. There's a lot of room for technology to do this. It's very complicated because of patient health, privacy acts, and different things like that. But it's definitely a big thing that people have been trying to figure out for the last 10 years. So there you go. We have a whole system, right? And this is really what exercise medicine is. We're going to engage patients in healthcare systems through providers, identify our at-risk population group. Maybe when you're starting out, you say, listen, we can't do everyone. We're going to focus on this. When I was working with the Ministry of Health in Taiwan, they said, our problem is our older adults. We are one of the oldest countries in the world. They become frail. They live to their 90, and they cost us a lot of money. So instead of the physical activity vital sign, they adapted it, and they now screen for frailty. And if an older adult comes in and they're frail or pre-frail, they're referred to the community resources. But we set up a community program to implement evidence-based frailty programs for older adults being referred over. So we have our at-risk population groups, we get them referred, and we can do anything with that. Combat obesity, different lifestyle behaviors, prevent NCDs, and use it as therapeutic and rehabilitation care. All right, so that's what exercise medicine is. Does it really work? That's the Cadillac version. I go in, I tell people, I said, listen, in a perfect world, if you could do all of that, that's really what you want to do. But maybe in your health system where you work, you can only do parts of it. Well, this is an example where they did it all. And they went beyond all. It's just absolutely exquisite. It's in Greenville, South Carolina. It's about 2 hours north of Atlanta. It's a smallish area. It's a town of about 200,000 people. But the health system, they have one large hospital, but they have about 50, 60 clinics scattered throughout 400 square miles of the state. So it's a very large health system serving a lot of people. So my colleague here, Dr. Jennifer Trilk, when she graduated from her postdoc or completed her postdoc, she went to this health system and she said, you're going to hire me. They're like, what? You're going to hire me because we're going to implement lifestyle medicine into your medical school, and we're going to start EIM. And if you've ever met Dr. Trilk, you know not to mess with her. So when she says she's going to do something, she's going to do it. This started in 2016. I think it wasn't until 2018 that she was able to get some of it implemented, and she got 2 clinics on board. By 2019, we were up to 12. As COVID hit, she was up to 18 clinics with exercise as medicine. Behind that, the entire health system had adopted the physical activity vital sign. So any doctor anywhere could go in and record physical activity levels for their patients. Then the clinics that had formally adopted exercise as medicine, they could go in and do order sets. And literally, it's one click of a button. I want to refer my patient to EIM. It's EIMG, Exercise Medicine Greenville. Click. Then it came up an option that says, do you want to give them one of those prescription for health? So yeah, my patient has diabetes. Click. Boom. It's emailed to them. Then that referral would go to a care coordinator. So someone's still within the health system, and she would get a notification. You got a referral. You got mail. She'd click on it and say, okay, my patient here got a referral. She'd get on the phone. She'd call the patient, right? This is the engagement part. So I see you got a referral. Tell me about it. Where do you live? We got 7 different places where you can go, but I want to get you to the best place. What are your needs? We have morning programs. We have afternoon programs. We have evening programs. What do you need? She works with the patient. So, okay, great. Let me connect you now to that site. And I will tell you, if you build it, they do not come. If you give patients a referral, they don't go. This last step, this navigator, this care coordinator was so essential. Now, she's really mad at us right now because since COVID, we've expanded to 35 clinics. She's getting like 80 referrals a day. And you're like, I can't follow up with all these people. You guys got to stop. Stop referring people to us. So well, there's a lot of people that need help. We're going to get you more people. So we're trying to get a second care coordinator right now. So that community side of things, we've partnered with the YMCAs. There's 6 in that area, 300 square mile radius. We have 6 YMCAs and 1 medical fitness center. And they've all identified a person on their staff that's going to be a point person. So when our care coordinator says, okay, I think this is the best YMCA for you, let me connect you to this person. That person isn't the exercise professional. They're just a point person. And that point person then calls you and says, hey, I see you've been referred to us. So it's a second step. Let me help you get enrolled in the program. Let me tell you what you need. The program costs $300. You don't have it? That's okay. We have scholarship funds for you. We've raised money. I think something like 72% of patients get some sort of funding. Let me get you enrolled in the program. Because of these handoff steps that they do, about 50% of people who get a referral actually end up enrolling in the program. And that's a really amazing number. It's a really high number. So a couple years ago, they said, well, does this work? And in this paper, showed the obvious. Like I work in the space of implementation science. I believe if you get people to physical activity programs, most people that go consistently are going to get better. They're going to become more active. They're going to potentially lose weight. Their fitness will go up. All these good things are going to happen. I don't think any of us doubt that, right? If we can get people to the programs and retain them. But when I got involved, I said, well, your referral rates, all the providers in these clinics, how many people are they actually referring? And I said, if they were referring all the eligible people, we should actually be getting thousands of referrals every week, because there's that many people that need help, especially in the southern United States. And I said, well, and who are the people that aren't getting referrals? Maybe some of those needy people that really need exercise aren't getting those referrals. So how do we get them the referrals, and how do we make sure that they get in the program? So this is the stuff our research is really looking at, not the program itself. We know the program works. We have great credentialed exercise professionals. We just got to figure out how to make that bridge, and that's what we're really working at. And it's just fascinating talking to the doctors and the nurses and everybody there about how we can do this better, because they have a lot of different pressures and competing demands. So my fourth section, I'm almost at the end. Hang in here with me, please. It's a little bit about EIM from around the world. When we started in 2007, we have ACSM members from every country and every part of the world, and they came forward and said, we want to be part of this. Bob Salas is such a great speaker. He gets in front of audiences, and I know he's speaking in New Zealand because the next day 30 people write me from New Zealand, I want to be part of this. And I go, why am I getting all these emails from New Zealand? And I ask, and yeah, Bob Salas is over there. He got everyone fired up. They want to do it. So that's what happened. People would be out talking. Hey, we got this new initiative, exercise medicine, physical activity awareness campaign. Great. Canada wanted involved. They're one of our first countries. Australia wanted to get involved, one of our first countries. Greece came along a few years later, said, we want to be involved. So it's really kind of spread that way. And we now have official EIM national centers, and we have some guidelines. We just don't give this to people. They have to go through a pretty rigorous process of establishing a foundation. And we have this in 35 countries, denoted here by the dark green. We have a presence in 40 countries. So we have some countries like New Zealand. In Sweden, they call it physical activity on prescription. Switzerland has a slightly different program. But we're all in the same battle together. We're all fighting the good fight together. And we're working to establish in other countries. And we have Greece, of course, started in 2016. I'm going to talk about a little bit of that at the end. So some examples. Canada, one of our first countries, about 6 years in, they got with the medical association, got a statement about development of a national system. They got funding to do training. Their EIM leadership team went around the country hosting these workshops, and it says 30, but I think this is actually probably closer to 50 or 60 presentations, and not presentations, I'm sorry. These are workshops where they get doctors in a room, nurses, people in a room, and teach them how to do exercise medicine. So it was really quite amazing, the extensive network of training. I've mentioned Singapore, another really great partner. They've actually developed their own textbook on exercise medicine. They do so many training courses that they said, we need a book. And they charge $50, $60 for the book. They sell thousands of copies. They have people coming through. They have 3 medical residency programs in the country. Every medical residency program teaches exercise medicine. The third point, mandatory training for physicians in the military. You're like, well, that's not a big deal. It's like, yeah, it is. They have mandatory enlistment for all males in the military. So every male physician is now being trained on exercise medicine. So 10 years, and then they leave the military and they go into private practice or work for the government. That means we're getting every male physician. And I say male because I don't think there's mandatory inscription for females, just to clarify. They've integrated PAVs into their major hospital system, and now it's spread to all the other hospital systems. And when you look at their list of partnerships, the list is lengthy. I mean, their advisory board has 40 different organizations from every corner of the country in all health disciplines. So it's just a fantastic example. In Australia, they have a really unique program I just quickly pointed out. They got all the exercise professionals in their association and said, we need your help. And they go into hospitals. I think they do this more virtually than in person, but they deliver these presentations to hospital teams. Now, it's really geared towards interns and residents that we want to train the next generation. But they go in and they do this, and they're trying to say, we know you're not getting this in medical school, so let us help train you on this. We have programs in Africa, obviously not quite as established there as we'd like, but in South Africa, they're doing some really cool things in medical schools, training exercise professionals. I'm involved in an initiative where we're going out and we're working with community health workers that go to the lowest disadvantaged communities, deprived communities, and trying to work with people to be physically active. And it's just amazing seeing this happen. Nigeria, led by a physiotherapist, they're really working through physiotherapists and their physiotherapy associations and Nigeria Heart Foundation. So we have some really cool things going on around the world. So I'm trying to do my best Bob Salas impression. I hope I'm getting some people fired up and a little bit more interested. Is it working? Anyone's getting a little? Okay. Hopefully at least you know it's more than an awareness campaign. If I did that, we're halfway there. She said, well, okay, I'm excited. I want to get involved. Don't write me because I just help support this team here in Greece. So I'll show you some ways that maybe you can get involved here in Greece. So we have a program called EIM on Campus. And we view the university campus, and I don't mean the physical campus, but I mean the sense of the university and everything it entails, as a microcosm of exercise medicine. So every university campus, and I know you have a very different structure here than we do in the US and other places, but almost all universities have healthcare providers working in some sort of clinic. Mental health clinics, student health clinics, employee clinics, almost every university has that. We have patients, right? The students, the employees, the people that go to these clinics. When I'm sick, I go to the occupational health, it's called at my university, and I get assistance. So there's definitely people that can do the assessment, prescription, and referral. Then you have exercise professionals because you have sports science programs. You are training people to do this. What better place to get them hands-on experience than with their fellow students and other employees? And you have PA resources, right? You have wellness centers. You have gyms on campus. Almost every university has these things. So you have everything that you need to do exercise medicine on your campus. Now, we do some really neat things. You can sign up to a global network. We have more than 200 officially registered programs, the majority in the US. But think about this, every program has 10 to 15 people, and we have 200 people. And those 10 to 15 people turn over every year because we have new students coming in and out. That means we're impacting 2, 3, 4, 5,000 people every year are learning what exercise medicine is. What a great grassroots initiative. And we do some fun things. We do a mascot challenge. You can search that, and they get silly with their mascots. We have a recognition program. Universities love this. Like, we're gold recognized, and they really fight hard to get it. So this is a great way to get involved. We don't have any official programs in Greece, and I know we have some universities. So if you're at a university and this grabs your attention, get involved. Go to our website. It's very easy to get this started. Very, very easy. But the biggest thing we do around the world is this healthcare provider training. I talked a little bit about it in Canada. Australia is doing it within hospitals. Today, we've trained almost 23,000 healthcare providers. And I'm not talking about talks like this. I'm talking about workshops, 50, 60, 100 people involved. But even at 23,000, that's just a drop in the bucket. And because we do research and we say, okay, medical schools are not training in physical activity. Australian medical schools are not training in physical activity. Nurse practitioner programs, not training in physical activity. Here's what we need to do. But we go out there and it's just not there yet. Now, I know we have a little bit here in the medical school, don't we, at the University of Athens. But it certainly has a long way to go to teach and make physical activity an integrated part of our medical school curriculum, nursing curriculum, physiotherapy curriculums. And then there's all the people that are out in private practice, the CPD, the continuing professional development that we need to do with those people. So there's a huge field of training left to do out there. If you work at a university and you're a researcher, we need your help. There's so much we need to know. How this is done in specialty populations. Cancer, exercise oncology is a huge area. We got to get those referrals for the cancer patients. What about technology? How do we refer to virtual resources, apps? How does that figure in? Older adults with the aging of our society, we have to get those people to evidence-based programs. And then how do we get other people involved? How do we partner with the physiotherapist, the occupational therapist? How do we get people to those programs or get them referring to our programs? And last, and really important, we got to go over the economic department and get the health econ people, because we got to understand if this is cost effective. Because the first thing when you go in and you talk to the government, and I'm sure they'll tell you this, they'll say, well, is this going to save us money? If we invest all of this into doing what you just said we should do, is it going to save us money when the patients get healthier? We don't know yet. We're doing that research, and we hope it's going to be fruitful. We think it will be. So if you're a researcher, we have a EIM Research Learning Collaborative. You can just Google this, sign up. We do sessions on research in EIM every couple of months, but we need more people involved in the research field. So my last slide here is really just a shout out to Greece. I mentioned they started in 2016. If you don't know them, they're an extremely proactive team. I mean, I'm so happy with everything they've done here. They've just been fantastic. And one of the things that they do that I haven't mentioned is the political advocacy. And I'm like, you did what? You went to the government and got this introduced and accepted into national policy? I don't think we have any other country that's been able to do that political advocacy like your group here has done. And if they continue doing these things, I think the sky is the limit, and I'm just so encouraged about what they're doing. But we need your involvement. So get involved. We need your help. So with that, I think hopefully we have a few minutes for questions maybe, or maybe I talk too much. But anyways, that's it for me. Thank you.
Excellent, Mark. Excellent. Thank you very much. Questions? Either in Greek or in English, or Chinese maybe. Yes. Professor Kokinos, yes.
Congratulations, Mark. Great talk and a great summary of all what's happening in the world regarding exercise medicine. As you pointed out, there are obstacles to overcome, and one of it I thought for years is the fact that we promote this 150 minutes per week of exercise, which is great. I have no issues with it, except we do have strong evidence to support that even exercise at 90 minutes a week is very effective, giving us significant results, yet we don't seem to promote that, and people get overwhelmed and with 150 minutes of exercise. What do you think about this? Do you have any thoughts that you can share with us?
Yeah, I think first is that comes back to the training part and teaching our future healthcare providers that any levels of activity are better than no level of activity, right? And understanding how to work with the behavior change. So we did a process with 77 different types of healthcare providers, and we said, what's the number one thing that healthcare providers should learn? And it's behavior change. And part of behavior change is learning to meet your patient where they're at. So yeah, if a patient came in and they were at 0 minutes, are we going to try and get them to 150? No, we're going to see what works for them to get them to 60 to 70 to 80 to improve their physical activity.
It's just not promoted. That's my problem. And
yeah. One of the criticisms we do get with exercise medicine is people are like, you're medicalizing physical activity, but we're working with healthcare systems. That's how they think. And so when they don't think about, when you look at blood pressure, they're like, we need to get you to this level. Like doctors and systems are set up with goals and benchmarks like that. And so that's our goal, but it's not, I mean, if we can do a better job training and getting people thinking like that, to understand it's a process. It's not going to happen tomorrow.
Yeah, it's my point exactly, that we need to start from 5 or 10 minutes a day instead of 30 minutes a day, because most patients will say it's intimidating.
Yep.
And they most likely will drop out because it's just overwhelming.
Well, if we can get them referred to those trusted sources, then that's up to us to train those exercise professionals to think like that.
Exactly. The trusted sources now have to do the proper.
Yeah.
Yeah. Thank you.
Yeah. And you know, one last point to that is one of the things I think we do incorrectly in some of the parts of EIM is they want to train doctors to be exercise professionals. And I'm like, that insults me. I've gone to school for 7 years of university study to be an exercise professional and know the things that you're talking about. I just want doctors to feel comfortable having a conversation. That's all. And give the referral to the exercise professionals that have that knowledge. So if I had to train doctors, some exercise is better than none. Get them active and get to people, programs, places that can really give you the guidance you need to keep engaged. Thanks, Peter.
Ερώτηση η κυρία. Το όνομά σας.
My name is Elpida Tsintsifa. I am ACSM certified, and I would like your opinion. What's your opinion or your suggestion of how exercise professionals can get involved? What would be the procedure, for instance, for Greece to get closer and do things, really do things?
Well, if you want to do something on a national level, I believe they have a working group or at least one person in charge. And I haven't seen him. Is Giannis going to be here? And he's working on the exercise professional thing. So you know, if you want to change things at a national level, they have a person doing that and doing the political advocacy. But I also believe that we all need to gain from this, right? So I talk to people, I was like, how can the research help your career advance? Or how can this help you advance? If you're trying to build your business, well, maybe you're going to try and connect with some clinics. Maybe through your doctor, through different things. Connect to them, and they'll say, yeah, I know you, I trust you, and I'm willing to refer my other patients to you. And so you're just starting in your small neck of the woods, and you can let them know so they can start developing a network, but they're like, okay, and that builds up your client base. And then if they're happy with you, they go back and they tell the clinician, and the clinician refers more people, and that's what you do. Now, it's really, really hard to do that because most clinicians won't even meet with you. But if you start with people you know, maybe your doctor, maybe some friends are doctors, and you start with a couple and they see your success, then they refer more and more, and then your reputation grows, your business grows, but you've helped EIM expand.
No, I understand that. I believe that I'm doing this, and I think we're all doing this. I'm asking in regard to AIM activities, of how can we all get connected? What is the plan? Is there a plan to get us involved? Is there a plan to get a recognition of who is actually able to work with patients that have health issues?
Well, and what we do at Global is we support the local country because we don't know the context of Greece. It'd be silly for us to come in and say, so I believe the next talk might actually even go over this a little bit, right?
Thank you, Mark. Please allow me to add some more information regarding the development of exercise medicine network at the national level. So a member of the board of the Exercise Medicine Greece National Center is responsible for developing such a network at the national level, not only at the national level, but also at the European one. And shortly, there will be an official announcement regarding the ways that we will come all together closer in order to become member of this network. As Professor Stoutenberg and dear friend Mark mentioned greatly earlier about the way that it will work at the national level, and If I may, I would like to ask dear friend Mark, after congratulating you for the excellent talk and the so important messages that you sent to all of us, since in the audience there are physicians, healthcare providers, but also, and of course, exercise scientists. Your messages were very important for all of us, and I would like to share with you and all the audience that the Exercise Medicine Greek National Center has developed a close collaboration with the Primary Health Care Association in order to come closer to that great achievement that Dr. Stoutenberg mentioned about the incorporation of the physical activity as a vital sign in the clinical assessment here in Greece. And we are close to this. I know you and also I would like to mention that the program that Dr. Stoutenberg mentioned about the exercise medicine on campus, we are in close collaboration with the university authorities and the rector himself in order to be this program developed in the University of Athens, the exercise medicine on campus.
Okay, thank you. A question here. Please, the microphone.
And while we're waiting for this question, to the last question here, Giannis, who's leading some of this, will be here. So keep your eyes out, and we'll try and talk to him. He might need some help. You never know. Okay.
Yes, yes. Dr. Pavlou, Professor Stoutenberg, congratulations for your fantastic presentation. For me, you made my day today. Why? Because I am one of the oldest certified clinical and exercise physiologists back in 1975 in La Crosse, Wisconsin. And I'm happy to see this movement. My question is this. I saw in all your slides, exercise is science, is medicine, and American College of Sports Medicine go next to each other. Who is going to certify the specialists to go on the market? Is it going to be the program that the SSM certification is going to continue on, or the locals exercise medicine centers will do it? How is it going to work?
Yeah, I mean, that's with all of what we've done, we've taken the approach that we're going to do what we do in the US, and if someone wants to adopt it in their country, we'll support them, but we really want them to come up with their own solution. So I will work with them and say, this is what we're doing in the US, but if you want to do what we're doing, you have to do, like an ACSM certification, you have to do exactly what ACSM says. So if you want to adopt what we're doing, you have to do it exactly the way we're doing it. Or you can develop your own. So in Singapore, their exercise medicine team is the premier certification team. So that's the best certification you can have in the entire country. So we really leave it up to the leaders in a country to say what works for you. An example, when I work with EIM in Philippines, they don't have certification there at all. It doesn't even exist. So they couldn't do what we do in the US. They can't afford to ACSM certification. It costs way too much for them with their salaries and different things. So I said, there's a great opportunity for you to develop your own. In Australia, they already have their own certifications. We're like, great, use yours. What the most important thing is you have to do something that the doctors and the health systems will trust. So I really say, go to your health systems, go to your Ministry of Health and say, what do you need? What do you need to see that you can trust us? And that's the most important thing, is to create that bridge. And that's typically my answer.
So what in a sense you say is that the quality of the trained personnel will be determined by the local exercises medicine.
It's a teamwork. It's a teamwork.
Yeah, it's co-producing it though. It's not an exercise professional saying this is what we have to do. It's exercise professionals working with health systems and saying, what do you need to see? Here's what we can do. What, you want an ACSM certification? All right, that's what we'll do. What, you want us to do this? Great, that's what we can do. And it's a co-production of building that bridge of trust.
That's good. Thank you.